All right, good morning, Pagosa. Big thanks to RG Bank for bringing us news, weather, and sports on this Friday morning. Happy Friday, TGIF, and all that. So today we're at the hospital again, and we're going to visit with Dr. Andrew Buck, who's the oncologist and hematologist and Cancer Center medical director. Also Jessica Cox, DO, PhD, diagnostic imaging. And you guys are pros on the radio, too.
We've been here a few times.
Yeah,
Good morning.
Right.
Thank you for having us.
Thanks for joining me here today after the open house. And so we're right back at it, right?
We're here.
And so, well, there may be some new listeners, so you want to start with your backgrounds first? And
Okay, I'll go. Thank you.
Go for it.
all right, Dr. Buck.
I'm Dr. Buck. I am the medical director here at the center. I've been here for about 2.5 years. We see a full breadth of types of conditions. So as both a board-certified hematologist and oncologist, we see a litany of oncology cases, whether it be solid tumor or liquid, but there's also a good amount of blood clotting disorders, meaning DVTs, pulmonary emboli, or some odd versions of those that we see as well that are not considered cancer. And there's quite a breadth of cancer diagnoses that are not referred to as solid tumors that I'm very happy to see as well, that are quite different from lung cancer, colon cancer, breast cancer, etc. So we see a very broad list of cancer diagnoses for being in a rural practice here in the Four Corners.
Interesting. Dr. Cox?
So I'm Dr. Jessica Cox. I've actually probably met a lot of you over the last handful of years. I've been here just over 4 years now. And a lot of times I hide in the dark in radiology, but those of you that have been in for any breast imaging, we do a lot of sports imaging and a lot of cancer imaging, so I work with Dr. Buck quite a bit. So I've probably met a lot of you over the last handful of years, or a lot of you have been into our department. So like I said, I've been here just over 4 years now, coming before that from the Front Range, so lots of different mixing and mingling of specialties, but I've landed down here and we love it, so I think you guys are stuck with me for a while.
That's good. A very good thing. So what are we going to talk about first?
So we've done this a few times,
Yes.
and what we try to do is talk about different cancer topics, usually based on the month. So technically right now this is a childhood cancer, which is not what I do for a living, and I'd have to make sure that's clear. I'm adult medicine only because we go through internal medicine, which is adults. But in just a few short days, it is breast cancer month. So Dr. Cox and I thought it'd be great to talk about some of the other imaging that we have available, because there's some big changes that our hospital is able to offer now, particularly with breast MRIs and 3D mammography, which has been a big game changer. A lot of patients have needed to go to imaging centers in the Front Range or elsewhere, particularly with a strong family history of breast cancer or personal history, whether or not there was a family history. And this includes people with genetic predispositions or not. And instead of having to go quite far away from our small rural community, we can now do that in our own community. But we're still beside ourselves of how many people aren't aware that we have both of these scans as well as an oncology department. It is not a huge department because we are a rural facility, but we have plenty of hopes and goals for long-term to make those changes in growth over time.
Yeah, so I think one of the big things, like Dr. Buck was saying, October is pretty famously now becoming Breast Cancer Awareness Month, and so that means a lot of things. Most of us either know someone who has been impacted by breast cancer, or us ourselves have had breast cancer, and so this is a pretty out there topic in the public, and like I said, most people's lives have been impacted in some way or another by this. The numbers that we quote a lot of times that you'll hear pretty frequently: 1 in 8 women will experience breast cancer in her lifetime. And so this is a campaign that has been, built up over the years to encourage people to come in and get screened, because we have really good screening tools. A few of them, like Dr. Buck was saying, mammogram, and for some people who need a little bit of extra screening, either ultrasound or MRI. And these tools are excellent in helping us catch breast cancers early and be able to therefore treat you earlier. So patients have better outcomes and they tolerate the treatment a lot better. And something really exciting that has happened at our hospital, we've had the capability to do breast imaging, so mostly mammograms, for quite a few years now. But it's been very exciting that in the last year, we have gotten our 3D mammogram machine. And we also have a very fancy new MRI scanner, which enables us to do breast MRI, which we weren't capable of performing previously. But it allows us to either screen patients, so any one of you that might be high risk, we can now perform that for you, as well as any patients that have been diagnosed with a breast cancer, we can use the MRI as additional imaging to help Dr. Buck figure out your treatment plan and kind of the goals of your care. So that's been really exciting in the last year, and so that's something that we definitely want to let the community know is available now, especially given the fact that, like we said, October is Breast Cancer Awareness Month.
Mm-hmm. Well, thanks. Yeah.
So I do want to jump on that comment. Now that we are starting to be able to feel more comfortable out in the open after COVID-19, there's quite a bit of patients out there of all health needs that have either not been coming into the primary care doc or not doing regular imaging and such. And I just want to remind the population, it's okay to come out. And I would really love for more patients to be caught up with their screening imaging. So particularly as we're talking about breast cancer here, it is in a woman's or a man, because men can still get breast cancer, best interest to stay on schedule with doing regular breast imaging. So for what I do for a living, I would always rather see somebody at a much earlier phase in their needs. And we can achieve cure very easily in comparison to when disease is caught very late. So for those of you that may be listening, if you are behind, I want to just please kindly encourage you to come in and have those scans done so that you don't have to come into the oncology experience, if you would, late in the game and more advanced disease. And the treatment is often far more simple and mainstream, and you often can avoid chemotherapy and such, and even sometimes radiation, depending on how early stage a disease can be caught. So again, just a kind request. Let's take care of our own, and if we know friends in the community that are behind, let's pass on a friendly reminder to them.
Yeah, which I think brings up a good point. I actually get the question from patients quite a bit when those of you come to see me that, what should I be doing? What is the recommendation? What is normal? How do I know if I'm doing it correctly? And what I tell patients when they come to see me is to know your breast. And like Dr. Buck says, obviously this pertains to women, but for men, this goes to you guys too. So know what's normal for you. And if something seems out of the ordinary, please don't hesitate to come see us. Your primary care provider is a great resource. They can help guide you and get you in contact with either the radiology department so you can get any of these imaging studies that you might need. Or if you need a little more advice or a little more counseling, then Dr. Buck's office would be the place to start, and they can also get you set up with them.
So when in doubt, if a patient were to find something on what we call a self-breast exam, make no hesitation to come in and see your primary care doctor and just say, hey, I found something. What do you think it could be? And I would rather people be more quick to ask these questions from their primary care doctor than to put it off. So best case scenario, you come in, it's not anything of concern, but you've done the imaging and we have peace of mind and there's no doubt about it. Worst case scenario, if someone finds something, thinks, I'll be fine. They put it off, whether they notice it growing or not. And I wouldn't want anybody to be in that situation. So please come in to see your primary care doctor far sooner than later.
Great advice. Thank you. And you're right, after the COVID thing, and people are still maybe staying home, and you don't want to get behind, and then it all kind of cascades or catches up with you, right?
Exactly.
Yep, agreed. It's far better to be more aggressive with your care than negligent, which so many of us are all guilty of.
Yeah, we are. It's time. It's whatever.
Agreed.
But,
and that's why that was kind of my plug with COVID-19. So many people are fearful to go just about anywhere. Mm-hmm. And part of that, whether it's the grocery store or any out in the open setting, it also includes for a lot of patients to not want to come in to see the doctor. Mm-hmm. So it is time.
It is time.
970-731-3700. Make an appointment.
Yes.
And let's see. So that's October, which is right around the corner. And then what else? I mean, there are other topics we want to cover now.
Yeah. Well, we've made our plug for Breast Cancer Awareness Month. But like Dr. Buck said, we're a small community facility, which means that we have a lot of opportunities to include other things in this. So we've also started using October as just General Cancer Awareness Month. And so, we've talked a lot about getting appropriately screened for breast cancer. We have a lot of great screening tests for breast cancer, but this also applies to other cancers that are very commonly found in the population. And two of them that I'll let Dr. Buck kind of take the lead on that also have great screening options are lung cancers and colon cancers. And those, like I said, are two that generally highly impact the population as well as breast cancer. So I'll let you take that.
Yep. So screening evaluations always start with a primary care doctor rather than going straight to an oncologist. And so this is part of their bread and butter daily, even just the annual evaluations with a primary care doctor is preventative care. And it's the idea of looking over your skin, whether somebody needs a dermatology referral or not. From 45 and on, recommended colonoscopies is when you start with that. So whether that's with one of the local general surgeons in the community that does colonoscopies or endoscopies, or with a GI referral to somewhere outside of our small town here, both are on the table as far as screening devices, again, from the age 45 and on. For those that have a history of lung cancer, a history of smoking brings up the question of lung cancer. I think everybody is up to date with the idea that smoking has a direct correlation with developing cancer. In fact, smoking has correlation with about 1 in 3 diagnoses in medicine in general, meaning it's not just cancer. There's a lot of other things that smoking is correlated with. But as an oncologist, I'll speak on this topic. So particularly if someone has had 15 to 20 plus years of smoking, whether this is in the past or current, the question comes up, should you have a low-dose screening CT? Without going into all of the details, I would say if that is you, go and see your primary care doctor. Whether you have quit in the last 5, 10, 15, etc. years, that is a very valid topic to bring up with your primary care doctor and to consider then a low-dose screening CT. It's not uncommon that we can find a very small pulmonary nodule, and hopefully not anything larger than that. And depending on what it is, these are things that then need to be followed over time to make sure they do not grow, they stay the same size, because there's various things that can cause pulmonary nodules. It's not all cancer-related. I think Dr. Cox will be better at clarifying what all of these things are. In my world, when it looks cancerous is when I get involved, but there is a large list of non-cancerous things that can be seen on CT of the chest. But long story short, any history that is prolonged, let's call it 10 to 15, and even up to 20 years especially, please see your primary care doctor. And we have imaging here that is right up your alley and appropriate to make sure we're not missing an important diagnosis.
Exactly. We can do these CTs here in the hospital. You don't have to leave town for them. So if this is something that your primary care provider and you have determined is appropriate for you, then we can also get you set up for that here as well.
Mm-hmm.
And I would say that this is right up there, just as women hear over and over the need for screening for breast cancer. The smoking population also needs to hear this. So again, same kind of story. If you yourself or you other friends, family, loved ones, if this fits them, the history of several years of smoking, then as a friend, as family, pass this on to them and say, please come and see your primary care doctor to make sure we're not missing this.
Yeah, and we didn't mention during the talk on Breast Cancer Awareness Month is some of the prevention ideas, and of course with smoking, it's quitting smoking, right?
Mm-hmm.
What are some of the other preventative things and that you can do, not just for...
So let's give a little plug on healthcare literacy.
Yes.
So be aware of your family history as far as their healthcare. As our families talk, whether we live close or we meet for our holiday events, be mindful of what everybody's healthcare history is. Cancer or no cancer, whether it's high blood pressure, cholesterol, etc. But again, I'll speak as an oncologist here. If you know of any primary or secondary relatives, primary meaning mom, dad, brother, sister, your children, that's all your primary circle, if you would, versus secondary is something right outside of that ring, but still considered related to you. Be mindful and keep track of their own oncology history and what the diagnosis is. And I would say we have to go beyond that, but then that also helps us interpret for ourselves what is our own personal risk and talk to your primary care doctor about that. So if an uncle or a few uncles and aunts and grandmas and grandpas, even if this is great grandmas and grandpas, these are topics to bring up with the primary care doctor and say, hey, should our screening evaluations be either more frequent or at a younger age than the recommended screening? So for example, if somebody has a family history of colon cancer or breast cancer or lung cancer, a general rule of thumb is to start screening 10 years earlier than the age your family member was diagnosed. So let's say there was a breast cancer in the family at the age of 45 or 50. Then screening starts at 35 or 40. So you always do it earlier, and this should always be covered by insurance. We just need primary care doctors to document this clearly, and you can start screening early.
I always wonder,
the same thing can be said for colon cancer, and as you go down the list of other types of screening devices. Sorry, go ahead.
Well, I was just, is there a way to diagnose something? Say your mom has something, but you're a male, you know what I'm saying? Do things transfer?
Absolutely. And so this quickly becomes part of a conversation to be had with a geneticist.
Yeah. Mm-hmm.
So there are certain genetic predispositions, without going into the letters and numbers and names of these genes, that for sometimes one mutation, there's 5 different types of cancers that could develop, right? So when you have one relative with what seems like a completely different cancer diagnosis than another, sometimes they are connected. Mm-hmm. All the more reason for your primary care to have documented in the chart a complete family history, mm-hmm. right? So for example, let's say someone does have a diagnosis of cancer of whatever form, and they come see me, and if I go into the chart and I see these correlations, I'll be quick to discuss that with a patient and say, hey, we should do this additional genetic testing, whether it's something that we do here regularly in the office, or it's something that we need a geneticist, someone who's far more of an expert in the genetics world, to get involved with, because there are various kinds of genetic panels to be tested to really get to the bottom of, could there be something that connects these dots, so to speak?
Right. That's what I was wondering. Okay.
But sometimes no. There's family histories of, let's say, 5 different cancers, and I don't know of a connection between that.
Right.
But sometimes the answer is, in medicine and science, we just don't know the genetic link yet. Mm-hmm. But that doesn't mean that one day we won't find that. Mm-hmm. But again, all the more reason for our histories to be up to date. Mm-hmm. And there are other kind of conditions that lead to a smattering of different kinds of malignancies, like Li-Fraumeni syndrome, where there's a genetic instability disorder, where there's not necessarily one gene that's the culprit, but it's the cause is poor gene repair. And that's a whole other topic. But if someone has lots of different cancers in their family, again, that's on the table of discussion, but you can't confirm that until you've done more testing. And if that is the case, that leads to a whole other discussion of screening for other family members, whether it be genetic screening or other imaging or procedures that need to be done to catch these cancers early.
And that's something that the primary care providers here at the clinic can help guide you through. We don't have a genetic counselor on staff in this particular hospital, but like Dr. Buck said, we can run a lot of these tests for these genes here through our laboratory. And we can also get you connected with a genetic counselor if that's something that either your family history is indicating or you have concerns about and you would like to speak with someone. That's something we can very easily set you up with.
And genetic counselor visits are commonly virtual visits. So whether it's over the phone or it's through some other kind of multimedia, it seems like the majority of those records I see in my office, at least, they're virtual. Even if you're at a very large academic or university-based hospital, there's someone sitting behind a computer somewhere that's doing those visits with you.
Yeah.
All right, so we're speaking with Dr. Andrew Buck and Dr. Jessica Cox. We're going to take a quick break. We'll be back in 1 minute. Good Morning Pagosa is brought to you by Archuleta Transit, the mountain transit right here in Pagosa Springs, Archuleta County, and beyond even. So we'll be back in a minute. Stay tuned for more Good Morning Pagosa. Okay, we're back. Thanks to Mountain Express for bringing us Good Morning Pagosa. We're here with Dr. Andrew Buck and Dr. Jessica Cox from PSMC. And we talked about the second most common cancer in men and women, and we talked about Breast Cancer Awareness Month next month, October. So now are we ready to talk about the third most common cause?
Well, that's colon.
That's colon.
What do you think?
Yeah, that's colon cancer. So we did talk briefly about this.
Yes.
So when in doubt, when you hear about friends, loved ones that are going to go get their colonoscopy, colonoscopies and screening colonoscopies have come about for this very topic. There's times to do colonoscopies because of various symptoms that you'll talk to your primary care and then a GI doctor for. But in general, the common practice of screening colonoscopies is to make sure someone doesn't have colon cancer and doesn't know it, even if they have no symptoms, right? So you don't have to have symptoms to have the diagnosis of not just colon cancer, but a lot of other cancers, right? All the more reason for a plug to be seen by primary care as you discuss your own symptoms with the primary care or you do regular labs. Primary care doctor is there to see the labs, see something that may be odd or fishy, and then let's say you just discuss even some vague symptoms that you may not think much of. A clinician's role is to then second guess or think through some of those symptoms to make sure it may not be leading up to some other unknown diagnosis. So on the topic of colorectal cancer, let's talk about the symptoms that can happen. The number one most common, I would assume, if it's not obstruction, would be new onset of anemia, meaning your red cells are low or an unexplained iron deficiency. So let's say you see your primary care provider and they say, hey, your red cells are a bit low and it looks like you have some iron deficiency. If there is no explanation, meaning there's no heavy menses, there's no other regular bleeding of some form to explain this, the right next step is to do a colonoscopy. So in our world, an unexplained anemia, otherwise unexplained iron deficiency anemia, is colon cancer until proven otherwise. And those are very strong words to use, but it's because without more information, we don't know how to interpret this situation. So again, that's where talking to your primary care doctor makes so much sense. So when someone has what we call bright red blood per rectum, you don't always know if this is something simple like internal or external hemorrhoids. There could be some bleeding hemorrhoids that still may require some sort of evaluation with primary care or a gastroenterologist. But what if those are not the source of the bleed? You would need to look further into this, and colonoscopies would be the right next step.
Beets. Having beets.
Having beets. Yes.
For dinner.
That would be the good explanation.
Oh, yes.
That would be a better explanation.
Yes.
Not to get too
than
graphic
a potential
or anything.
cancer.
Yes. So, yeah, because beets, it's funny because there's a hereditary pattern for this, but there's a protein that we can all break down, and I think more of us have the red urine from eating beets, but yes, also dark, bloody looking, right? So excluding a dietary source. So meaning, not everybody looks when they wipe. And this is not a very happy topic that people want to talk about, but the truth is we should. To make sure we're not seeing any, let's say if it's dark blood versus bright red blood. Sometimes that can mean something different. All of them are a reason to talk to the primary care doctor and clarify what could be going on. So going back to the topic of colon cancer, when in doubt, colon cancer can cause some bleeding, whether this be a little or a lot, or a very slow, let's say a drop equivalent of blood, because as cancer grows, it invades into the various layers of the colon lining. Ultimately, colonoscopy is the best resource, as Dr. Cox may know. I'm sure she does, excuse me. You can't always see this on a CT.
Correct.
And unless this is quite obvious for what we call the apocore lesion, a lot of times the only way to finally see colon cancer is with, you call it the naked eye, but it's a camera. The colonoscopy being able to see it. And when you've seen enough colonoscopies, you know the difference between normal gut lining and, let's just call it, a big anomaly, because they come in different forms. So while this may be graphic, it's the kind of topic to bring up to encourage the idea of why it is that we truly do colonoscopies. And especially if you have a family history of colon cancer, all the more reason to be on top of doing regular colonoscopies.
Mm-hmm. The worst part is the prep, right?
Always.
That's what I hear.
Always the worst part.
Yeah, I don't know any way around that. So there's a lot of tests they're trying to discover as an alternative to colonoscopy. There's various hospitals that use these as alternatives. I believe in a tried and true concept, and especially when we get into smaller rural communities like ours, we don't always have those tests available to us. So it takes us back to tried and true medicine.
Very good. Okay, so we covered just about everything.
I think so.
What do you think? And if there's anything else, let me know. But I encourage people to stay in touch with the hospital and have that number ready, 970-731-3700, and make that appointment with your primary care physician, right?
Exactly. And a point that I don't think that we've made is you can always call that number, say you need to make an appointment to see a primary care doctor. If you don't have one, we can help get you set up with one that you feel comfortable with. We have lots of options of people here that are going to take great care of you. And if you need one of these screening studies, so the nice thing about the screening mammogram is you don't need a referral, you don't need a doctor, you don't need anything to do that. So you just call the number for the hospital, say, hey, I need a screening mammogram. We get you set up and we go from there. Some of the other ones, like we were talking about, some of the screening for the lung cancer, like the CAT scan or the colonoscopy, those take a little more than just a phone call to get set up, but that's a great thing to talk to your primary care provider about, and they can do all of the quarterbacking to get you set up for those kinds of things. So the main number, call, say, hey, I need to set up and get screened by my primary care doctor, and I need a mammogram. So do it. It's October. It's a great month to do it.
And while there's going to be a scheduled date, which may be somewhere down the road, there is also the option of the walk-in clinic.
Right.
So as far as I'm aware, 5 days a week. I don't know if they have Saturdays too.
Not currently.
Not right now.
But Monday through Friday, there is always the walk-in clinic, meaning it's not an ER, it's not a quick care, it's a approved schedule where one provider always rotates through these responsibilities. There's not just one provider dedicated to this, and it's inside the primary care department. And you basically can, like you would a quick care or an ER, but not for that severity of a need. You just show up, meaning this is a very open, again, invitation that you can just show up.
Excellent service, I have to tell you. Really. And
we are here to help you sort through it. So if you don't know where to go, just show up and we will get you taken care of.
And whether that's a cough, cold, flu, or some nagging symptom you've been putting off for a while, the door is open.
Very good. Well, thank you guys.
Thank you so much for having us.
You bet.
Thank you.
And have a wonderful weekend. Happy Friday and all that. We're live at the hospital today. and just a great place. We're so proud of what you guys do and our facility here. So thanks again.
Thank you again.
Thank you. Happy Friday.
Yeah, we'll see you later.